Thanks for joining Navigating Data Complexity Across the Health IT Ecosystem webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode, but if you have any questions, please type them in the questions section on your GoToWebinar console. At the end of the presentation, we'll have a Q&A session as well. We'll get to as many questions as we can, but if for any reason yours is not addressed, someone will be able to follow up with you after the presentation. We like to keep things interactive, so throughout the webinar, we will be launching poll questions for you to answer. Today we have two speakers, Dan Exley, he's the president and founder of Exley Informatics, and Matt Cardwell, vice president of client services at IMO. As mentioned before, if you have any questions or comments while our presenter is speaking, please type them into questions on your GoToWebinar console. And with all of this being said, I would like to pass it over to Matt Cardwell.
Great, thank you so much, Jory. Appreciate it. Dan, pleasure to be speaking with you today. Before we launch into the conversation, and just by way of a little introduction about myself as well as IMO, I've had the pleasure to be here for about 10 years and gotten a chance to see this germ of an idea around clinical interface terminology emerge into something that has largely penetrated the United States. And I think it's been a phenomenal trip for myself, being able to serve most of the US care delivery market in a variety of roles here at IMO. I've gotten to see incredible transformation in our business, as well as the industry, things like meaningful use, our transition to ICD-10 CM here in the States, and then a growing presence internationally. I think one of the most profound shifts that I've seen is that the discrete clinical data is now a reality, one that IMO has been a pronounced force in helping to deliver. And some of the more aspirational uses of data that we dreamed about are finally being brought to fruition. Dan, as we enter into the discussion, I'm curious for your view. You were an early EHR adopter, one of the earliest IMO customers in my memory at one of your previous health systems employers, and so I'm really curious just for you to talk through and enter into this conversation by what do you see today that's different from back then?
Thanks, Matt. Yeah, it's been almost 20 years since the big enterprise deployment of an EMR that was one of the first in the country. Really the first enterprise Epic install, and short on the heels of that was the recognition that we needed to improve the content in the electronic medical record to help with the adoption and use experience of our clinicians inside of the EMR platform. Back in 2002, 2003, our greatest concern was the safe operation of the system and the adoption and utilization of the system. The organization that I was working with at that time was really committed to a deployment of the system to its fullest capacity, and the big part of the priority there was make sure that it works for the doctors. And so that was what led us to the partnership with IMO, starting with diagnoses content, and then expanding onward to other content areas there. And that was then, of course, the case at other organizations that I worked with over the subsequent couple of decades. The things that we were worried about then aren't really the case today. We were, as you mentioned, meaningful use, that program, for all of its faults, did significantly move the needle to the adoption of those technologies across the industry. And where we stand today with interoperability is a tremendous position for us to be in. And it was a dream, and it's been really exciting to see. I mean, it's taken now a full generation, but it's cool to see that the capabilities are there. And in general, you've got your clinicians using this technology. Now, That's brought about new problems, but it's also brought us to a level of new possibilities. And the things that we're working on are, how do we now get the value out of the data that's there, and also increasingly do a new pass on what it means to improve the way that clinicians interact with these technology platforms. At first, it was just, there was literally no way, for example, to document that a patient had a knee surgery at some point 20 years ago. Generally speaking, there was a CPT code list, and that was too specific for a physician to go to the medical history activity or the surgical history activity and say, by picking from a codified list, what happened to that patient, even if it was not really known the specific details of, what was the approach for the procedure, for example. Now we've got different issues, and we need to come back around, and there's a lot of work that's being done, and it's exciting to see how we can say it's too complicated, it's still not user friendly enough, it's too much, and how can we now start to use technology to do a further pass at improving the way that clinicians are engaging with technology, and then also, excitingly, get more value out of all that data that's being collected.
Yeah, no, that's a great way to frame the conversation. We've got all of this data and we need to do useful things with it. And so the frame for the conversation today, we're going to cover 3 different entities that you see on the screen here: integrated delivery networks or health systems, unique challenges that they face, what health information exchanges are doing, how they collect data and serve their participants and other entities, as well as clinical data registries. Certainly a lot of commonality in the macro challenges that they face, but differently felt based upon each of those segments: control of the data, influence they have, what they can do about it. And so we're going to move into a conversation on those 3 topics. But before we do, Dan, given your perspective, I'm curious to know, challenges that you're encountering today that you didn't foresee those couple decades ago. What's different now? What's surprising to you?
Well, I think it was, we didn't have the bandwidth or the specifics to really understand what are the nature of the problems facing us when we go to solve why physicians work after clinic for hours each night, and what do you need to do to go and solve that. We just knew that. I remember sitting looking at a patient's record a few months after a go live, at that first go live 20 some years ago, 19 years ago, and reflecting on the fact that the list of encounters and the list of labs and the list of meds was growing, and we were only a few months in. And of course, that was the whole point. But just it started to become clear that we had we were going to have an information management problem of the next level. If you think about it, aside from the actual conducting of surgical procedures or processing a lab test, most of what we have in healthcare is an information management discipline. And so where we're at today, the most cutting edge technologies that exist to help us with information management at scale are really compelling. If you think about what's possible, not even like we dream of it, but we know that there are use cases for how massively complex and unstructured data are being used in other industries and other use cases. We know that those things are possible in healthcare if we choose to. And something that you and I have spoken about, and I've spoken about with many of my colleagues over the past few years, has been, generally speaking, while there's tons of room for innovation in its purest form and invention, largely the technology that we could use to solve the problems that are vexing us as an industry exist. We just haven't made it a priority to figure out how to leverage them within a much more complicated industry like healthcare. So I think that we knew that there was a class of problem heading our way a few decades ago, and we've certainly seen organizations make great strides with building an analytics team, figuring out a modern way of doing data warehousing, figuring out how to adapt those tools that were maybe only designed to work with financial data and structured data, or only unstructured data, but not with a healthcare ontology underneath it. We're starting to see organizations make progress there, But I think there's still, in most instances, a very assembly line approach and a very descriptive approach to how those problems are being solved. And as a result, we've only seen organizations be able to move yay so fast because they have to pre-build everything, for this patient population, for that service line. And we are clearly at a point now where every service line, every leader is being expected to take advantage of all that data and all those systems that you're generating all day, every day to help you drive fact-based decision making. And the things that we've been really trying to do, with limited exception, haven't been successful in equipping the industry to move at the pace to really understand how we leverage all that data. And that's where we stand right now. It's everybody feels like it shouldn't be this hard. Like, how come I can get so much else in my world comes through digitally, dynamically, in an elegant way, and yet when I sit down at the EMR or I sit at the head of the boardroom table, I still feel like I'm operating in the dark. We need to solve that, and that's the big opportunity for us within this part of the industry, I think.
Great overview of where we stand today. As Jordan mentioned early on, we want to make this conversational as much as we can via webinar. And so just to get to know a little bit more about those of you that are joining us today, so we can focus some of the topics a little bit better, want to know about who you are and either where you work or who you primarily serve.
Thanks, Matt. So which of the following segments do you work or primarily serve? So integrated delivery networks, health information exchanges, clinical data registries, or other? I'll give you a few more seconds to respond. All right. I'm going to go ahead and close out. Thank you to whoever responded. We are kind of at a mix, Matt, between other and HIEs.
All right.
Great, thanks all. So we're going to step into the conversation first around integrated delivery networks and follow the data, right? I think a lot of the clinical data is generated within EHRs, other entities. So Dan, opening the conversation, obviously this visual omits a lot of detail. I know just before we chatted, you were showing a network diagram of another health system and all of the complexities around an interchange engine. So that this is obviously not that, but starting first, over the last year, we've spoken on some of the transformational things you're doing with your clients, and just how they're using data to respond to the COVID-19 pandemic and using that as a leverage point for both aggregating data and doing interesting things around that data. So maybe start there and just describe some of the unique and innovative things that your health system clients are doing.
Yeah, I think for each of these use cases that we're discussing today, if you're a data science or data analytics guy, you probably have heard the V's related to big data, and there's, depending on who you talk to, there's 3 V's, 4 V's, 5 V's, but at a minimum, volume, variety, and velocity. The core 3 V's of like when big data first became a buzzword. It's almost a decade now. Those V's are confounders for many organizations, whether you're an IDN or you're an HIE or you're operating a registry in some capacity or another. And to my previous comments, I think it's been challenging and in some cases paralyzing, and in other cases, a lot of work's been done to put governance models in place that allow for the organization to make sure they're spending their time working on the right things, because there's just so much. And so it depends on what you're looking at, whether you have a storage issue or whether you just have a ton of very tiny records, whether you're talking about the imaging data and the metadata associated with that and you need petabytes worth of storage, or if you're looking at all of the data that might be associated with genetic sequencing related to a COVID-19 lab test, for example. The nature of the data is different, but it's still, in the interest of the pandemic, it's really helped us across the board, whether you're good at prioritization and governance around information management in healthcare or not. We were able to have focus in ways that we weren't able to have pre-pandemic because everybody was working to solve for that. Now, of course, in a system that's as large as this, we have many sub-missions operating in parallel, so there's still been some requirement to prioritize, but it's been very easy to get to a sense of priority and get decisions made about where should we work. I think the things that have been encouraging to me on the health system side, large IDNs and medium-sized organizations have been the extent to which we've seen a willingness to partner, not only within the walls of an organization, and as you know, an IDN typically didn't come about from native organic growth with a leadership team that's been intact for 25 years. There's been a lot of M&A over the course of the past few decades, and there's been a lot of change up in recent years for some of the generational transition in the leadership ranks. So there's a lot of things that are new and disjointed, even within the walls underneath the logo. And I've seen a lot of move towards systemness, which has enabled us to say, hey, we've always done these things differently, but now let's really say we're going to standardize to this, or we're going to agree to sit down and talk about how we harmonize system A and system B. In the middle of the pandemic, we're not going to change over to one platform for imaging, for example, but at least we'll be able to make common use of data from two places in ways that were maybe problematic before because we didn't have the will or the need to come forward and solve for that. But the other encouraging bit has been the extent to which we've been able to innovate on how we've been integrating data from outside of the walls of the organization, where you don't have a common medical record number, for example, where you have really no insight into the nature of the structured data that's being shared with you, what clinical practices are, what's the nature of the data quality, but being able to very quickly and within the bounds of what's allowed regulatory-wise, bring data sets together. And that's been in partnership with public health. It's been in partnership between health systems that maybe were frenemies at best or strong competitors within the market, but it's been encouraging to see leaders come through and say, we'll give you the executive support and cover and funding or whatever else you need to help us make sense of the data that's going to let us care for our patients or support our providers. And so those are, I know those are very broad brushstrokes, so they're not like a technical innovation, but again, we don't have a lot of technical problems that we don't know, like how would we possibly solve that? It's more like it's complicated, or we can't get people to get on the same page, or we haven't been approved to purchase that, or we had a regulatory restriction or an in-house legal concern about a cloud out migration that many other of our peers have already done. And the pandemic has removed a lot of those barriers or brought people to the table and enabled that co-innovation. So that's been the thing where we've now, like, I never had access to system A, B, C, or D because of some multiple myriad reasons. And because of the pandemic now, it's been like, well, what will it take? How soon can you get systems A through D online, live, and connected with a real-time connection if you can? And the great news is for the organizations that I work with, they have competent teams and they have a good starting foundation and that freedom to then go do and say, oh, well, we can do real-time integration for that. We just need the following things and remove those barriers and get it done. So more real-time access to more systems then, more cross-organization collaboration within and beyond the walls of the organization, and then bringing more content up through so that leaders can really rely on it and trust it. And that's been, I think, one of the most gratifying things for my clients has been the extent to which they've really met the call, and they haven't been, that very early on in the pandemic, we were able to say in ways that were shocking to people, like, we can normalize data between places, we can bring it together, we can work really hard and do it, and you can rely and make decisions on this, and it's not going to come back and burn you. And those were some pretty remarkable things. And there have been some neat innovations within that too, starting to use unstructured data in novel ways. working with more of the precision medicine sequencing data in novel ways. And those have helped support an understanding of which direction the pandemic's heading, or how we do staffing, what are the barriers to discharge, a whole range of things. Those have been some of the things that have been really exciting to see over the course of the past year.
How are you making use, Dan, of data outside of your own four walls, or four walls proverbially, right? Do you see encouraging signs towards improved data exchange?
Absolutely, and we've demonstrated what's possible to care for a community with hard work and cobbled together solutions, I guess would be the fair thing to say. We've been operating in quadrant one, urgent and important action mode for more than a year now. But people have seen that, oh, if we do this, we can really care for our community better. We can facilitate communication between providers better. And we've seen first order benefits from that, but I think the second order benefit is going to be, and that will lead to further improvements and innovation in that space to make it actually really work. And we'll talk about this a little bit more, I think, when we talk about the health information exchange's role there. But even aside from the community HIE participation levels, just how organizations improve the way that they're using data between systems within the system and with the other organizations in the area, whether it's public health or the private-public partnerships. It's been really remarkable to see that advancement. So the degree to which we can expand that from really caring for one population and treating one condition with a lot of really hard work and patch something together that works, it's functional, but it's not pretty, and it's only doing effectively one thing. But people, I think, have now caught a little bit of religion, and the question will be like how quickly we can start to move that to expand it to something that's scalable, repeatable to other conditions, and really becomes a fabric of how we operate as the health system that's system of systems caring for a given community in a service area.
Well, I know that we could probably spend hours talking about just the health system in general, and we certainly have in the past. But how about we use that as a logical transition point, Dan, to talk about the health information exchanges that are a part of this network as well.
Yeah, I've participated in so many work groups, collaboratives, industry teams over the course of the past 20 some years. The HIE, the RIO, the CHIN, all its various forms and names and regional variants. And I'm really familiar with some of the problems that are sort of practical or regulatory or legal or risk in nature that the HIEs have had to really wrestle through and still be viable and be an active tool for community benefit. And it must be gratifying to those that have really led the charge and pushed through, because we've been able as a country to realize great value from the HIEs during the course of the past year. I know several of the regional HIEs that my clients have interacted with. If you looked at the website for a given HIE, you'd see the logo of most of the organizations, if not all of the organizations in the region. But the level of participation and the level of integration has been historically different. So you might have one organization that stood up a full integration and is sending, real-time ADT about every admission and discharge, signals about lab results, et cetera. And other organizations maybe are sending only some signals and every so often. Some organizations are realizing the benefit, when an emergency department physician walks into the room and opens up the record and the EMR, that's a part of their native workflow. Maybe they see a tab and with single sign-on native integration of the workflow, oh, here's the information that's only stored in the HIE that tells me about what happened to you yesterday at the urgent care down the street in a different organization. But other organizations haven't provided that level of integration for their clinician flows for one reason or another. So maybe, yes, their clinicians can use the HIE portal, but the way they do it is get the patient's information, go log in on a different terminal in a different browser, pull up the portal, authenticate in, look up the patient again. There's nothing integrated about that flow, but technically the ED physician, if he really wanted to, she or he could go and get that information. And then what they get when they get there is maybe variable as well. I'm not exactly sure what they might see there. But we've seen enough benefit over the course of the last year, and the link between the HIEs and the public health entity has actually been a pretty good one in a lot of instances. And so that was an early part of the conversation, was how are we going to help track on lab results for this pandemic and getting ready, and then how we're executing and how we're tracking on vaccines, and does the HIE have a role on how information gets to the city, county, or state vaccine registries or onto the feds. And there's been a lot of sort of renewed appreciation and value generating activity around the HIEs. So I've been tremendously encouraged to see that, and I've been appreciative of the fact that we've had that sort of public utility in place in a lot of places. I'm hopeful that over the course of coming months, we will see an increased level of standardization in the degree of a higher degree of participation across all the logos that are stating that they're participating, and also a standardization around how we get that information into the clinical workflow where it's helpful, whether it's a doctor's office and you can see that they had a second dose of Moderna yesterday at a community clinic, or that there's a lab test result from yesterday from somewhere else. Like all that stuff, again, it's technically possible. Will we prioritize and see that everybody, the clinicians that need that information, uniformly have it in a way that's integrated into their flow? And I'm very hopeful that that'll be the case. Now, as that happens, and we do have more participation and more data coming in, we'll have, again, other types of problems to solve for how we make sure that it's deduplicated correctly, or that it's normalized between the different systems, or that the ways that orthopedic surgeons document over here is a little bit different than the way that orthopedic surgeons document over there, and how we make sort of sense of all of that. But those are good problems to have, and that's something that folks at these organizations have been ready for and doing to some extent, but maybe not to the extent that they will need to. So I think that'll be another part to this, is how do we see the right mix of public-private funding to make sure that these utilities, if you will, are staffed to support the needs of the communities that want to leverage them, because that's obviously been one of the big question marks over the years, like who's going to pay for this, how much are they going to pay for it, what's the benefit to it, and it'll be exciting to see how that goes. And I didn't think we were going to see like a fifth or sixth wave of the Rio Chin HIE conversation, but I'm glad that I'm hopeful that we will, because it will be for a really good reason. I think we could see some real big benefits clearly accruing back as a result.
No, I think that's totally true. That as I look out at the space right now, I think HIEs, and I sometimes hesitate to use that term. I know that's that's what's in common parlance today, but I was cautioned early on by a leader of an HIE. Health information exchange is a verb, right? And you use the term utility, which I think is likely more apt, right? They've invested, they've innovated, they've built out this core infrastructure that I think they're having a moment truly, and I think it's really ours to collectively unlock all of the value that they can be providing for us. Certainly you speak to business model innovation, and that intersected with data quality and uplift of that data. I don't know if you saw it just a couple of weeks ago, Dan, but there was a great article in Jamia talking about the power of this community record, if you will, and looking at patient data and how that data was benefiting the overall quality reporting when you incorporated other clinics within that same network. And that speaks to the power of aggregating the information, but then also the power of the information exchange to provide an uplift to that data.
Mm-hmm.
Talking with an architect, another HIE, we're working together on a lab normalization exercise right now. How you introduce LOINC codes back into lab data, incredibly important for any of the type of surveillance that we need to do today, be it for COVID or influenza, other important other activities. And just 5 of their participants, one of the larger HIEs in the country, only 5 of their participants, including 2 commercial labs, were sending LOINC data. So incumbent upon them to be able to figure that out, and how we can send that data to the right place and provide those types of value-added services. So I think it's going to be incredibly powerful to see what we can do, the increased flow of information, how we're providing value back to those participants and other entities that need to make use of that data built on the foundation that already exists across the country.
Yeah, I think there's an opportunity for leaders in this space, whether they're at a payer or a provider, the HIE itself, public health leadership, to make sure that this opportunity is not missed. Because if you were to ask what's the, aside from lab testing and vaccinations, if you were to do the word cloud for this space over the course of the past year, telemedicine, telehealth is clearly right up there. And there's a lot of conversation about, oh gosh, it was so great that we got waivers and we got people to pay us to do this, and that we didn't have to, we put the technology in place. Super powerful, super important, super overdue, and I'm very glad that that's been the case, and I'm very hopeful that we won't see a drift back exclusively to original models, both on the payment side or how the care is delivered side. At the same time, the power of the HIE, to your point, the verb aspect of that, however this is being conducted in a community, needs to persist, and it has to be something that supports the little guys in the community. They're independent group practices with a small EMR that can barely do a CCD, but it can, and they can contribute, and they want to get back in to the multi-state system that of course they'll participate. They do it in all of their areas. Like, we need to help to normalize that playing field, make sure that the benefits accrue back out, and really have a focus on those ambulatory care providers. But the same principles of waivers, temporary solutions for another year to help get all the vaccination data and lab testing data back out to all the care providers who need it, because it was collected in so few places around the community. Use those as the excuse to say, like, hey, can we get a little bit of freedom here to have a community medical record number, for example, that blends the crosswalk, and somebody fund and go do that, so that every care provider can have the insights that they need to help care for these patients, to know if this is a long COVID case or not. I mean, there's so many different use cases there, but if we don't speak up, we may not see it happen, and that's incumbent upon us as leaders to speak up and make sure that that's not lost in the shuffle, or that telemedicine isn't the only voice that's being heard.
Yeah. Dan, you mentioned just how we think about different diseases, treating some of those patients. Certainly not an HIE. Now, if we zero into some of these use cases, but clinical data registry, a little bit more focused on specific disease classes. Leading into this last part of the conversation, could you share your perspectives as from the health system side, participating in these, and we can open up to some of the unique challenges that these entities face.
Yeah, and I think about CDRs in a few settings. One, clearly, a health system has registries for tends to be populations that they have some degree of undue burden or risk associated with, or that there's some kind of a trial or a specialty institute within their organization, whether it's related to oncology or neuroscience. And there are registries within every organization. They definitely tend to have variable depth, variable size, and the extent to which you can expect to find the same degree of value out of each one of them is also variable. So I think there's opportunity there to bring more information into the CDR, but of course it goes beyond that too. Public health was represented on the partners or the inbound side for the IDNs, and certainly a part of the conversation with the HIEs, but the public health departments have been working with registries as well. And then sort of on the opposite end, either the payers or the national associations or the regulatory bodies, everybody's looking to keep an eye on different populations for different reasons. The exciting thing over the past few years, so set aside the pandemic for a second and just like, okay, meaningful use is in its first form behind us. Pretty much everybody went along with that and has some form of a system in place. We've got a lot of information that's being collected. Of course, as we discussed, a lot of it's still siloed, but there is more information being captured, whether it's discrete or unstructured. There's data there that we couldn't get at before that we've yet to see make it consistently and standardly into the registry, wherever whoever's operating that registry or whatever disease process we're talking about or patient focus that we have for the registry. So there's a lot of opportunity for us to help the operators of the registry, in a sense, get more of that data in to paint a clearer picture of the information that's relevant to the focus of that registry. But I think in parallel, that allows us to redefine the scope of what a registry contains, and also the way that we think about the value of the registry. In some respects, I could see us. We know that our patients aren't just diabetic. We know that our patients don't just have cancer. Some of them are, some of them do, but multiple patients, particularly in this country, but a lot of others, we have multiple comorbidities, and the sickest of them are the 2+ chronic, 3+ chronic that are on the watch lists. But if you take that thought process around, there's very rarely only one thing going on with somebody who's got something significant enough going on to put them into a disease registry, if you can, instead of just like a general population registry. Then just looking at their A1C and their other related lab values traditionally for that disease process may not be enough, because we're not getting the full picture of how all those comorbidities interrelate. And we also haven't really put a lot of data science broadly on top of a large collection of data to actually understand a bit more of the categories of the tapestry of all the different ways that persons who are maybe previously thought about as being hypertensive or diabetic, they don't simply classify. There's actually a many subclassifications, but we've not had the data together to do it. And then we also haven't had the funding or the time to take something like advanced machine learning and go through and say, how can we really understand what's going on so we can bring the right trial opportunity, the right novel medication therapy opportunity to a patient that would be more likely than not to respond correctly or participate. We have the ability to, the technology exists so that as I've been browsing the internet this morning and reading the news, all the ads that have been popping up have been probably, despite the browser's best attempts to neutralize cookies and the rest, they're still relatively targeted towards my persona, even if they don't know who I am, and they probably do know who I am. The types of ads, in some cases the very specific ads, are somebody's paying more to have them shown to me because I might have a little bit more chance of clicking through, and if I do click, then they'll pay more. But that's that degree of, that's coarse, right? That's not real precision like we talk about with precision medicine, but that's much more targeted outreach than most of what we do in healthcare when we say, I want to engage a certain type of population, I want to track that population, I want to follow up with them, I want to reach out with them, and I want to talk to them in a way that's meaningful to them so that they're most likely to be on board, go along with me, make it to their appointment, participate in that trial, be a good patient and take their meds, follow up and check in, all those things. So that's the promise. And when we think about the registry opportunity, that's where we said there's the virtual framework, not the like hardened physical registry with 50 predefined fields, but more that sort of concept of I get the opportunity to now start with the question of, we know there's a problem with patients crashing in with their diabetes unmanaged, but to look then broadly. And then I think that fits into something else you were saying, which is there are disease processes which are not the top 10. They're not diabetes and hypertension. They are diseases which maybe only have a few dozen representatives in a community, for example, and you might not even know that most of them exist because they haven't come to your facility, or it hasn't been diagnosed yet. And I think that by having sort of the whole system of data wired, that's going to enable us to do some of the things that people have talked about. Doctors being able to open up the chart, see a patient, but then also sort of look through their panel automatically, or all of the panels of all of their co-workers and partners in the practice, and say, let's talk about patients like mine or patients like ours, and start to see, actually, we have a few patients that are like this, and here's been what's happened to them. These folks keep going to the emergency department. These folks, they've tried this med 3 times and they've always switched off of it. Should I even bother trying with this one? Even absent like advanced sequencing and pharmacogenetics. That's where we can go. And that's, but as you know, that's again back to like, what do we have? We don't have a technical problem. We have an information management problem. It's not that the data doesn't exist. It does exist now. It just exists in different forms, in different ways, in different places. And we haven't brought it together to then start to solve that information management problem. But if we do, think about how powerful that is to have that equivalent of like, I log in my patient portal, I don't get like just the mammogram reminder or just the prescription refill reminder, that really there's sort of a robust platform underneath that's helping me be aware of all that's going on and all of the opportunities, and is engaging to me in a way that's maybe different than when you log in and see perhaps the exact same thing, but in a different way. And that's the promise of like the next generation clinical data registry work.
Yeah, I think that's so true, Dan. Really, having the right tools, implementing them the right way. You brought up the concept of those diseases, disorders that affect a small percentage of the population. I was just looking at this recently. The NIH maintains a list of genetic and rare diseases, over 6,000 in fact. We have all 6,000 plus in our diagnosis terminology. Contrast that with only 10% of them covered within ICD-10. So there's not a chance of being able to resolve, find, address those patients. Short, even that's even if they have that diagnosis, let alone in the example you shared, right? Just being able to understand them as full people, not just an MRN in the system. And so I think that's certainly ours to unlock. It'll be exciting to see where we go from here. And I think tremendously powerful to hear your stories over the last year and certainly the last couple decades, Dan. Before we close out the conversation today with some Q&A, we do want to launch one more poll question. So while you're answering that, if there's questions that you have for myself or Dan, please get them into the question box, and we will respond to them in kind.
Thanks, Nat. Okay, so if everyone could turn their attention to the screen, rate the importance of data quality to your organization. So is it very important, somewhat important, 50-50, less important, or not at all important? I'll give you guys a few seconds to answer. It's looking like about 76% of people think it's very, very important. But that's awesome. All right, I am going to go ahead and close out, and now we can begin our live Q&A session. If you have any questions from today's webinar or questions you had coming into the webinar, please enter them now, and Matt and Dan will begin answering them live. Just a reminder, as we start receiving questions, please excuse any brief silence for them to review.
No, thanks. Dan, looks like we've got a few coming in here. I know you talked a good bit about the organizational transformation that you're seeing during COVID, Dan. Any low-hanging fruit that you would point to, right? Things that you might not ultimately have thought about over the last year, but you found incredibly successful, or maybe quick wins for those organizations that you've partnered with.
Yeah, I mentioned already the value that can accrue from cross-organizational data sharing. We overcomplicate it, and it is complicated. If you want to do, like, I want to fully marry up, system A and system B and have bidirectional interoperability for our labs or something on the order of an HIE. But for focused initiatives, and I think increasingly as we're looking to do the public-private partnerships, and by public, I mean like public health and private health system, whether they're not-for-profit or for-profit, whoever's caring for the population, we can get over ourselves and we can get some cover for saying this is legitimate, we can do this, it's covered by HIPAA, we're not into any trouble here, and we can set up some it's HIPAA compliant but low-tech ways that have high value for information to be shared between organizations. Now, as we do that, we still have to be able to be prepared to get to harmonize that data. So there's a little bit of work to be done there. But my experience and that of my clients has been that we've got decent folks on both sides of, or all sides, where the public health department's got smart statisticians, and we're complementary as well, right? Organizations haven't taken exactly the same approach on how they hired or staffed or which technologies they selected. And most of us don't have a bunch of public health statisticians hanging around and able to help. And so putting those skills together and getting the cover to do some focused information sharing has been one yielder of great results. I think another thing that's sort of low-hanging fruit is that we overcomplicate how hard it is to get data. We got to go through the EMR committee to add a new field into the record so we can capture something on intake into the emergency department. And I'm, as an informaticist, lifelong informaticist, I know why and I believe in and endorse the approach of saying it needs to be native in flow. I think, as my friend Ari always says, like, the worst thing you can say to a physician is those 3 words or 4 words. You just go to, that other portal, that other tab, that other link. You've lost them. But at the same time, there are a lot of ways that we can collect data that's otherwise like been in a spreadsheet and get into a database table really quick so that our machine can go and grab it, use it, and surface it for the morning briefing of the executive team and the nursing huddles. We overcomplicate things a lot. And so I think that this has shown that some of the things we've done have been totally a hack, and I don't want us to do them again. But to the extent that we can take advantage of tools we have from Microsoft or tools we have from Amazon or other things in a portal from another data integration tool where you can say, you know what, I want to define a data model and structure, I want to stand up a form, and somebody can give us data and we can have our counts and we can have real-time insights, or can we leverage an API and just kind of quick and dirty drop it in there? If it meets the level of data quality and timeliness that the workflow needs, well, let's go do that and not kill it. Sasha and Jane was talking the other day in an article he published in Forbes that some of you may have seen about, the awful burden of the ways that health systems burden ideation and innovation, and the 3 or 4 different ways that it's death by committee, or we need to get a full endorsement and everybody has 100% approval before we take one next step, or death by pilots. And that resonated so strongly with me. There's been an increasing willingness to JDI, just do it. And we need to keep that spirit going, and we'll see more low-hanging fruit and being willing to experiment, at the same time being cautious that we're not knowingly creating like a laundry list of technology debt that we're going to have to unravel or make somebody else's problem.
Mm-hmm. No, thanks for that. I'll start this next question here, and maybe Dan, if you can layer in a question being, what is IMO doing around this challenge and data normalization specifically? And truth be told, we did launch a product specific to this area last year called IMO Precision Normalize. Really intending to leverage our strength as a foundational terminology across healthcare to be able to serve these diverse needs, be able to restore clinical information that's gotten lost along the way, code information that might not be coded, and I think distinguishing us in this space is that really that's future-proofing that data. It's not just adding back a LOINC code, but it's adding back that foundation of IMO terminology support to ensure that as new regulatory needs emerge, that IMO as a terminology provider to the healthcare industry can be there to meet those needs for the industry, just as we have for the last 25 years. Dan, I'm curious. We've talked about this some. I know there's some projects that we're looking at together. Why do you think of IMO in this space, and what do you feel would be particularly meaningful to those organizations, as well as others that we did not talk about today?
Yeah, I remember seeing some of the previews of the work that you and your team were doing, developing the precision normalized tool set, even a couple of years back, and saying, I have this germ of an idea, we're working on these things. I remember being so excited about that because the class of problems that we've been describing, the information management problems that we have of volume, of variety from so many different silos within and beyond the walls of a given organization and all these different use cases. We can't solve those problems one at a time. And realize the benefit that our organizations and our patients and our providers need. Like, you just can't go through and build only the top 10 diseases. You can, but it only gives you a certain amount of reach. And you guys have been moving into not just providing content, but providing software solutions and integration services in ways that were being driven by the needs of, the providers, using the EMR and the problem list as a bear still. Yes, you can see more things in it because of IMO's content and the sort of the relevance, like the examples you gave, all these specialty conditions with small populations, and there's no ICD-10 code for that, and maybe no SNOMED code for that. And so I almost filled that gap, and you were helping to make it easier for people to work with that. But the things that we have to do to solve a lot of these problems are largely machine-driven and automated and dynamic ad hoc. We need to be able to say, I open up the record and I'm entering the account for a patient, or the encounter for a patient that I haven't seen in 6 months. They've seen a lot of different places. They've been seen at other places within my organization and beyond my organization. I open up their record. The things that I need to know probably can't have been pre-built. Some things that I know are important to the administrator of the shared risk, the shared savings plan or the risk pool, those will be in there. I need to make sure they're getting their mammograms and doing all those things right. They've been in there since the beginning. But the more nuanced things, and like what's really going on with this patient, what are things that I need to know about, and bringing that forward out of multiple places, you can't pre-build those. And we need to use, the IoT approach, the service bus, the service bus, the technology platform, and the APIs that would allow us to bring those things together dynamically. And so I was excited to see what you guys had started to do, and I'm excited to see how organizations of a variety of kinds are going to take advantage of that for that dynamic creation of meaning at the point of need. There's no way that we can pre-bake it all, and so we have to have something like these services, either one transaction at a time or in bulk, the different modes that those tools can be used in, to really help organizations across a variety of, bringing new insights out of all that data.
Well, I think that's a great place to wrap our talk today, Dan. Again, thank you so much, Jordan. I'll turn it back over to you to close us out.
Thanks, Matt.
Awesome. Thank you both. So we're going to go ahead and close out today. I hope you found everything in this webinar useful. If you want any more information about IMO or IMO solutions, please contact your IMO client executive, or you can email sales@imohealth.com. Thank you for attending, and please stay safe out there.